Welcome to the webinar, A Guide to Integrating Emerging Therapies into Current Treatment Paradigms for Hepatocellular Carcinoma. This program is provided by North American Center for Continuing Medical Education, LLC, and is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated. I'm Ghassan Abu Alfa, medical oncologist from Memorial Sloan Kettering Cancer Center, and I'll be your presenter today. These are my disclosures. My goal in speaking to you today is to discuss emerging agents, including immune checkpoint inhibitor therapies that enhance survival for patients with HCC who have disease progression after sorafenib, evaluate the PK and PD profiles, efficacy, and adverse event data that are emerging regarding newer TKIs and IO agents as monotherapy and or in combination for management of HCC, and interpret recent results and ongoing clinical trials pertaining to therapeutic strategies designed to improve patients' outcome in HCC. The agenda for today will let me introduce TKIs, discuss them in details, followed by the checkpoint inhibitors or immuno-oncology. We'll talk about chemotherapy, and we'll finish by discussing combination with local therapy. As far as the TKIs, as we all know, the story started with the SHARP trial, a phase 3 randomized trial that randomized patients with advanced HCC to a drug at that time was novel, a tyrosine kinase inhibitor called sorafenib versus placebo. Patients who had advanced HCC with appropriate performance status, Child-Pugh scoring, were randomized to the sorafenib versus placebo, with the primary endpoint being overall survival. As you can see here, the trial was positive, with a median survival of 10.7 months in favor of sorafenib versus 7.9 for the placebo, clinically and statistically significant. This led to the approval of sorafenib by the FDA as well as other agencies worldwide and became the standard of care as of 2007. While it provided an important answer to what we were all aspiring for as a therapy, it also posed many questions, among which, who are the patients that will respond better to sorafenib? In this depiction from the study done by Dr. Anli Chang about sorafenib versus sunitinib, which was an active study and reconfirmed sorafenib to be the standard of care, nonetheless, we notice over here that a patient who receives sorafenib, if they were to have hepatitis C and are from ex-Asia, their median survival can go all the way up to 18.3 months. And if a patient is from Asia with HBV, the median survival will be about 7.9 months. Understandably, this does not mean but the drug, of course, works for everybody, but clearly it appears to be the outcome might differ based on etiology and ethnicity. 10 years passed by without necessarily any positive trial, despite genuine and incredible efforts done by groups worldwide, until the advent of the Resource trial, which was a randomized trial for a drug called regorafenib versus placebo that was offered to patients who have advanced HCC that received prior sorafenib and progressed on the sorafenib. So they were literally able to tolerate the sorafenib, but they progressed on it radiologically, and they were offered as such the regorafenib versus placebo. The trial was positive, as you can see over here, with a median survival of 10.6 months for the regorafenib versus 7.8 months for the placebo, again clinically and statistically significant. The two drugs, regorafenib and sorafenib, are relatively close, but nonetheless they have certain differentiation, and interestingly enough, the acquired resistance to sorafenib is driven by activation of IGF and FGF that might be important signals that the regorafenib can attack. And if anything, this led to an understanding that the regorafenib, as a distant cousin of the sorafenib can have different attributes that will be most importantly after the progression on sorafenib. Interestingly, in an unplanned study, it was seen that patients who received regorafenib as part of the resource trial and prior sorafenib beforehand, the cumulative median survival for this population from the start of sorafenib till the progression of regorafenib was, and of course until death, it was 26 months. A pretty impressive number that we should definitely acknowledge. Afterwards, we heard at the ASCO in 2017 about the advent of a novel drug called Lymphotinib, another multi-tyrosine kinase inhibitor, which already is approved for other malignancies, with a high focus on FGF, and in a rather impressive design. The trial allowed patients as a first line of therapy for advanced HCC, of course with Charge-Pugh-A, to receive either Lymphotinib versus sorafenib, with the primary point being overall survival, but in a very innovative approach for looking as non-inferiority. The reason of the non-inferiority was not an attempt specifically by the sponsor, but we understand that the agency has supported that approach, considering that with the advent of the many therapies, it would be appropriate to look for non-inferiority at that time. With this said, the trial was positive. It shows here, as you can see, a median survival for the Lymphotinib of 13.6 months, which is equivalent to the sorafenib 12.3 months, and there was no significant difference between the two. Add to the equivalent median survival between Lymphotinib and sorafenib, it was clear that Lymphotinib had certain advantages reported, including a doubling in the progression-free survival and also an impressive response rate by modified RECIST of close to 41%, and also by RECIST 1.1 close to about 25%. Many of you may recall that at the time of the advent of the sorafenib, there was a serious interest in regard to c-Met inhibition, considering that it attacks the hepatocyte growth factor, which of course the liver is very abundant with, and as such an effort was done with a multi-tyrosine kinase inhibitor with a c-Met activity or inhibition called Tivantinib, and as we can see here from a randomized phase 3 trial in second line, Tivantinib versus placebo, there was no difference, and if anything, Tivantinib did not work. A very important note in regard to that study, that it was specific to patients with high c-Met, because based on a phase 2 trial, it was noted that patients with a c-Met expression which is more than 50%, 3 to 4 plus by immunostaining, did not fare well without therapy, 3.8 month median survival, where the c-Met low patients had 9 month median survival. And as such, there was a argument that the trial will be best fit for patients with poor outcome with the high c-Met, and this whom it was offered to. Another drug at that time was evaluated called cabazontrib, which, as you can see here, was also studied in a phase 3 trial, looking at cabazontrib versus placebo, with the primary endpoint being overall survival. This trial, whom I had the honor of leading with an excellent team of colleagues worldwide, was actually offered for all patients, regardless of the c-Met expression. This was our argument that we cannot really determine how much of a c-Met expression is needed. At the same time, we don't have determination that the c-Met is the sole player for that drug because it's a multi-tyrosine kinase inhibitor. With this said, the trial was positive. It shows here a median survival for the cabazontrib of 10.2 months versus placebo 8 months, which was clinically and statistically significant. While the drug is already approved for other indications, I would not be surprised that it will also be approved for the indication in second line in HCC. a new advent that was reported at ASCO this year, Rameshwaram, another multi-TKI that was looked into the HCC population originally but was negative. However, a notion that for patients with high alpha-fetoprotein more 400 might fare better. As such, REACH2 was a clinical trial that looked at the Rameshwaram versus placebo in patients with advanced HCC who progressed on prior lines of therapy but has an AFP level at baseline of more than 400. And as we can see over here, it was positive with a median survival of 8.5 months for Rameshwaram versus 7.3 months for placebo. No doubt that this advent of multiple tyrosine kinase inhibitor creates for us a complex picture. Here, as you can see, the big picture shows 5 agents with positive data, and at least so far, 2 of them have been approved, being sorafenib and regorafenib. As you can see here, however, what to choose and how to choose will be very much dependent, could be on toxicity, but could be also based on biology. Talking about toxicity, no doubt that sorafenib and regorafenib will probably share one of the common side effects include, which is hand-foot syndrome, which no doubt is appropriately can be managed by preventive approaches, including some emollient creams and, of course, some repeated evaluations, and of course dose reduction and interruption as deemed necessary. I would not necessarily say that this will be a adverse event that will be limited the use of the drug, of course, except if it's not taken care of appropriately, or of course in the uncommon instances where it could be rather pretty advanced. Lymphotinib has the problem of the hypertension, which definitely should be taken care of, but thankfully this will be easily manageable anyway. And cabazontrib has the fatigue, and Rameshwaram is multi-TKI again with multiple side effects, yet we are waiting yet to see the details when they are reported. As far as activity, no doubt the sorafenib, the hepatitis C story, which I mentioned, could be a favored approach, even though the drug can work for everybody. The regorafenib prior to sorafenib is a requirement, and the lymphotinib, no doubt, has multi-approaches in regard to therapy, and I think the focus on the high response rate will be very valuable. The cabazontrib is still yet to be studied in details, yet no doubt that the up to 2 lines prior therapy will be a valuable point, and of course the Rameshwaram with the high alpha-fetoprotein story. It has been a fascinating year in 2017, and if anything, not only that we had the advent of multiple TKIs, add to them 2 that were reported in 2018, being cabazontrib and Rameshwaram reported as positive and still waiting approval, but also we have the advent of the checkpoint inhibitors, which are reported over here with the phase 2 trial of nivolumab that at that time was more concerned about the potential for the side effects from the nivolumab, and as you can see here, the early study looked into patients without viral hepatitis versus hepatitis C versus hepatitis B, but interestingly, with the advent of the study and the expansion to the multiple cohorts, shows very clear from this swimmer plot that patients did respond regardless of the etiology. Actually, based on that data, which actually reported a response rate in the range of 16 to 20%, the FDA gave a conditional approval for nivolumab pending the advent of this phase 3 trial looking into nivolumab versus sorafenib, which we are waiting for to be reported. Checkpoint inhibitors were not only evaluated in the first-line setting, but also in the second line, and similar to the nivolumab phase 2 data, there has been data on pembrolizumab in phase 2 that was reported already multiple times, but again, awaiting for the phase 3 trial that's looking into pembrolizumab versus placebo in the second-line setting. Not only that, but also another advent is the combination of anti-CTLA-4 and anti-PD-1. As we can see over here, the approach to use of an anti-CTLA-4 blockade to attack at the lymph node level and then create a further environment for the anti-PD-1 at the tumor level is reported elaborately in regard to the biology and has been tested in a clinical trial, among which a current ongoing phase 2 trial looking into durvalumab as anti-PD-1 and durvalumab plus tremelimumab as the anti-PD-1 plus anti-CTLA-4 versus tremelimumab. Actually, this led to the advent of a randomized phase 3 trial that already has launched called the Himalaya study, which include 4 arms. One of them is durvalumab, one of them is the combination of durvalumab plus tremelimumab, and the third is the same with the different dosage and timing, and the last one will be sorafenib. Of course, we'll await for that data to be reported. With the advent of so many TKIs and so many checkpoint inhibitors, no doubt that one might wonder if there is any role per se for chemotherapy. And as we can see over here, the FOLFOX versus doxorubicin data that was reported in JCO in 2013 by Dr. Shen and colleagues from China shows that there could be a potential benefit for the FOLFOX per se, which of note is already approved by the Chinese FDA. The reason we got interested in this specific therapy is because we attempted to use ADIPEC20, which is an arginine deaminator that will remove arginine from the cells, which is an essential amino acid that will, no doubt, with its removal cause cell death. But more importantly than the drug itself, the HCC cells lack the enzyme arginine-succinate synthetase, which you can see to your right-hand side with the red arrow, which the lack of that enzyme will lead to the lack of repletion of arginine from citrulline, and as such the cells will die. We attempted in a randomized phase 3 trial ADIPEC20 as a single agent versus placebo, and unfortunately this did not pan out. However, the combination of the FOLFOX plus ADIPEC20, which we attempted in a phase 1 trial still ongoing, has shown actually a clear benefit, and actually there is a clear biologic argument for the use of the ADIPEC20 in addition to fluoropyrimidine and the platinum. And that trial, which we already reported as an abstract, has shown that there's clear response rate, as you can see this in this waterfall plot, which actually tripled compared to what we know about FOLFOX. FOLFOX will cause a response rate of about 8%, while here we have 24%, which is nicely depicted here in the CT scan as comparing the baseline to the left and the response after 4 months to the right. An attempt for the combination of local therapy plus systemic agents have been ongoing for a long while. We can, of course, quote the SPACE study that looked at the combination of tyrosine TACE, or the transarterial chemoembolization plus sorafenib versus TACE alone. Unfortunately, they did not show any improvement in outcome, as you can see over here, looking at the overall survival. This was also reported the same way, not to be beneficial in regard to in a study reported from the UK called TACE2. And however, at this year ASCO, we heard about the TACTICS trial, which was a phase 2 trial of TACE plus sorafenib, which interestingly showed a evident improvement in regard to the time to untreatable progression, a new definition that we are not necessarily have experience with, that showed an improvement in favor of the TACE plus sorafenib. The median TTP was also improvement, yet the overall survival was not reached. This definitely will at least bring a revisit to the TACE plus sorafenib, even though for now I would not necessarily recommend it until we have a better understanding of the TACTICS study because of the trials that I showed, which is the SPACE, and the one I spoke about, which is the TACE2. A similar attempt is being looked for the combination of the theraspheres, the yttrium-90-based radioembolization plus sorafenib, and despite first attempts of comparing the theraspheres to sorafenib that did not work, a combination of the two will await for the results of that ceramic trial. Not only TKIs are being looked at in regard to combination with local therapies, but also the checkpoint inhibitors are. We can see here effort that was reported on tremelimumab with different forms of local therapy that showed rather suggestive of an improvement in regard to outcome. And if anything, a current ongoing trial of TACE plus nivolumab is underway. As we can see here, this not really based on different dosing, but rather different timing, where the nivolumab will be given after the TACE, before and after the TACE, or through and through. And we are waiting for the results of that trial. The approach to local therapy is not only dependent on TACE. Actually, an advanced phase 3 trial is still ongoing for Pexavac, which is a vaccinia virus with an altered TK, which has direct dead cell lysis, adaptive immune response through GCSF, and vascular shutdown, which will be combined with sorafenib. And of course, we're waiting for the results of that important trial as well. With this, I leave you with a summary stating that tyrosine kinase inhibitors evolved up to 5 now, yet all are limited by the safety profiles. Immuno-oncology agents have defined an evolving role in the management of advanced ACC, yet with the conditional approval of nivolumab, we're waiting for the phase 3 trial data. Chemotherapy role is yet to be further defined with that combination of the IPAC-20 that I mentioned. Systemic therapy in combination with local therapy is still underway. And the Pexavac study, again, is underway. Thank you very much for your attention. Please stay tuned for a question and answer session.
Good afternoon, and thank you for joining us for today's webinar. My name is Ghassan Abu Alfa from Memorial Sloan Kettering Cancer Center, New York City, New York, and I'll be your moderator for today's question and answer sessions. And joining me today are my co-presenters and colleagues, Dr. Lewis Roberts, gastroenterology and hepatology from Mayo Clinic, Rochester, Minnesota, Dr. Riyad Salim, professor of radiology, medicine, and surgery, and chief of interventional radiology at Northwestern University, Chicago, Illinois, and Dr. Myron Schwartz, professor of surgery at the Icahn School of Medicine at Mount Sinai Medical Center in New York. Welcome aboard, everybody, and as a reminder, if you would like to ask a question, please type a question into the question box, and of course, we'll make sure that we all will contribute here to help out the discussion to make it alive. Thank you. And I'll start here with the first question to Dr. Schwartz. Myron, tell us a little bit more about HCC from your perspective. What will be in your mindset if you were to really define one thing as being the make it or break it for surgery versus no surgery?
Well, the considerations are both with regard to the underlying liver function and to the extent of tumor. As far as liver function is concerned, if we're talking about resection, we have to be quite strict if we want to achieve reasonable results, especially since what can be achieved with non-surgical approaches, as Dr. Salam, I'm sure, will contribute, has improved to the point where there's really little room for morbidity and mortality in liver surgery these days, so that we only operate on people with normal liver function. That doesn't mean that they don't have cirrhosis. The majority of our patients have cirrhosis, but it's with normal liver function, a child's class A. If we need to go into that, we can, what that means, without portal hypertension. Those are the people where we can consider surgery. Now, as far as the tumors are concerned, we have lots of technical capabilities. We can do a lot of interesting things, but from a biological standpoint, the cases that are best are single tumors. Size doesn't matter in this situation, but tumors that are single and that are in such a situation that we can remove them without removing a large portion of the functioning liver.
Great. Thank you so much. That's extremely helpful. And if anything, I would like to carry on that discussion with the advent of one specific definition, which is the portal vein involvement or not. And if you don't mind, I would like in sequence to hear again from Myron, what will this mean in regard to surgical resection, the portal vein involvement, and at the same time the portal vein involvement from your perspective, Dr. Salim Riyad, what does that mean, and where does this fit in, especially in regard to radioembolization?
Yeah. Well, there's no question, even among surgeons who are advocates of resection in people with portal vein tumor involvement, that it's an extremely powerful risk factor, a predictor of recurrence of cancer after surgery. From a technical standpoint, if the tumor is confined to one lobe of the liver, the right or left portal vein, or the segmental branches more peripherally, resection can be carried out. But increasingly, we have taken a position that while guidelines say systemic therapy, and there's no question some patients can be cured, we don't like having 80% early recurrence. And so that we now, I think this is a handoff to Riyad, will treat the patients loco-regionally with, in most cases, radioembolization, and observe what the course of things is over time. If the tumor is excellently treated, we'll sit. If the patient develops disease in the other side or in the lungs, then we know that resection would have been a bad idea. And if over time we see that there's still viable tumor in the treated area, but there's nothing showing up anywhere else, then we will consider going ahead with resection. That's our current strategy. Of course, with the advent of this effective systemic therapies, we commonly, outside of protocols, will combine systemic therapy with such an approach.
Oh, thank you, Myron. Riyad, your thoughts?
Yeah, so there's no doubt that historically the patients with HCC with portal vein thrombosis and involvement have had sort of a relative contraindication for embolotherapy in general, like chemoembolization, because of the risk of ischemic hepatitis. But certainly with the advent of radioembolization, which is sort of a minimally embolic therapeutic load, there has now been sort of resurgence of interest of local regional therapy in this specific patient population, the advanced patient population. And so certainly, to sort of echo what Myron was saying, what we're excited about over the last several years is the use of a local regional therapy, particularly radioembolization, to sort of deal with the HCC, in many cases cause shrinkage and retraction of the HCC. Median survivals range from 12 to 14 months in sort of patients with good liver function. But very excitingly, we've seen a lot of patients now with such significant response that they go on to get liver resection. You embed sort of a biologic test of time, and I'm sure Myron has seen those patients. And in fact, there are now a series of patients, and people are observing those that do well for 2 or 3 years now go on to liver transplantation, even though it's a contraindication. And so there's a lot of interest in using this local regional therapy, radioembolization in portal vein thrombosis, and in those patients that do really well, hyper-selecting them for resection and transplantation, even though they're not in the guidelines, because that's the nature of sort of personalizing care in this patient population.
Yeah, when it comes to those patients, we used to treat them, and if they were good for 3 or 4 months, go to surgery. But we started realizing that a good number of them on pathology had no viable tumor detected, and so that we've changed our approach. And as long as the situation looks like there's a complete response after radioembolization, we just sit tight until we see some evidence of viable tumor.
Great. Well, thank you both. This is extremely helpful and very guiding. And we'll switch subjects a little bit. And we had a great question here that I would love to hear the thoughts of Dr. Robert Lewis. What's the place of immunotherapy in the treatment of patients who are waiting for a transplant? And, of course, this is from the perspective of what the pre-transplant situation might cause in regard to interaction with immunotherapy. That's interesting. We had the question before in regard to post-transplant, but let's start with this novel one, pre-transplant. What do you think?
Yeah, so it's a great question because of the evidence that we have so far that it looks as though with immunotherapy, we're able to achieve some fairly durable responses in a proportion of HCC patients. And I think the question particularly is what happens if patients are, for example, immediately pre-transplant, are going to go into the situation of having a transplant and need immunosuppression. Is, what's the, in a sense, the duration of the effect of immunotherapy on their immune system, and then does that affect their ability or their risk of rejection when they receive a transplant? And I think that's something that's still, I think, incompletely understood. It's interesting to see a number of strategies that people are beginning to try to use in the post-transplant setting, but I think in the pre-transplant setting, that's not completely clear. The question, of course, that sometimes arises is if you do have someone who goes on immunotherapy and then has a durable response, that person at the very least could potentially have their transplant delayed and may potentially even never need transplant. So that becomes another factor as well.
I think something that Ghassan, I think that you should address. The transplant patients commonly have altered liver function. They're not necessarily Child's A, and we've always avoided using the TKIs in such patients. But it's my impression that the immunotherapy agents are maybe easier to tolerate in people with worse liver function. In that sense, would they have a better role in patients with Child's B waiting for liver transplant?
Absolutely. And actually, along that line, I would like to ask you, Myron, another question. So the aim, of course, of the question that was brought up, and of course, we had great answer from both of you from the perspective of the safety of an intervention of that nature. But the question is, of course, the checkpoint inhibitors are kind of like mainly perceived as having great responses, even though it is there. But I understand it's limited to about 16 to 20% based on the NIVO reported data. But with this said, if I were to have, and I'm putting here a theoretical question, but to illustrate the point, if I have a patient with a lesion which is, let's say, 9 centimeter, and I use checkpoint inhibitor, and now it shrinks all the way to 4 centimeter, and now technically by definition it's still a transplantable lesion based on that size as per the Milan criteria. And of course we can use any criteria per se, but let's assume within that context I move the lesion from being not resectable, not transplantable, to become eligible for liver eligible for transplant. How do you perceive that? Is this like for you a 4 centimeter to begin with, similar to like a 9 that became 4, or how do you read this?
Well, the concept of downstaging is big in liver transplantation, and it never made much sense to me, because if a big tumor has risk of having begun to spread, then what you do to the tumor in the liver is just cosmetic. It doesn't take back the cells that may have begun to leave, But nivolumab actually is a very different thing. The way we've always done downstaging is with chemoembolization, with ablation of the tumors, local regional treatments to the liver that have no potential to impact on the likelihood of spread. So it's actually much more appealing to me to think that we could downstage a tumor with nivolumab than with local regional treatments, because if you see the tumor in the liver shrink like that, then there's some reason to hope that maybe there's been an effect on the extrahepatic spread that's undetectable. So I think that, unfortunately, it's like you said, only 20% of cases, but I think that would be a much better way to do it than the traditional way.
Absolutely, that's very important. So to kind of like translate what you said is like we're treating ourselves rather than treating the tumor over here, and I hear your point very loud and clear there. So while we're on the subject of checkpoint inhibitors, Dr. Salim Riyad, there has been quite a bit of interest in regard to combination of local therapy being either chemoembolization or radioembolization with TKIs, specifically sorafenib. And let's start there. Maybe you can tell us a little bit about the current experience, the most recent reported data in that regard. Teach us there.
So obviously with the advent of the SHARP data in 2008, there was sort of this initial interest that by default anything you would do from a combinatorial fashion would sort of improve either time to progression, PFS, overall survival. And certainly there have been some studies and some combinatorial studies, and there's been sort of an initial disappointment, obviously, with the data from SPACE and others in terms of whether the addition of a TKI to, say, chemoembolization or drug-eluting B is able to prolong PFS or TTP, et cetera. And so there's been sort of an overall disappointment of that. There certainly is some interest, and one of the criticisms has been, is the endpoint correct, et cetera. And now certainly with the findings of the Tactics clinical trial, which we're anxiously awaiting sort of some more of the detail, is if we sort of refine the endpoint to be a bit more relevant, to include sort of local regional therapies, the number of treatments, when to treat, is that something that is to be considered, and things like time to treatment failure or time to sort of conversion to a different treatment, is that something of interest? And that's something that I think we're starting to look at. But I think you're also alluding to checkpoint inhibitors. I think certainly now with the advent of those findings, there's sort of a renewed interest in combinatorial treatments, and we're all anxious to combine that with the immunotherapies, and we're doing that here certainly, and I know many other places are doing it, because again, there's excellent partial response rates. There are patients that respond for a very long time, and of course, the abscopal effect that everybody continues to look for is really something that is a combinatorial concept. And so there's a lot of, I think, renewed excitement in these types of concepts.
I think perhaps also another question that comes up is the potential for combination of the checkpoint inhibitors with the receptor tyrosine kinase inhibitors also, where I think that there's also, I think, anticipation. There seems to be some early phase data that suggests that we see perhaps substantial benefits with combining those two classes as well. So I think that's also quite interesting, and it'll be interesting to see how these play out as we get into the phase 2 and phase 3 studies.
For sure.
Absolutely. I totally agree. If anything, I wanted to go back, however, to Dr. Salim. And you mentioned already Tactics. And can you tell us a little bit more about like that novel endpoint that was used there? And do you think it's really just a kind of different way of reading a positive outcome, or is it really have value down the road for like something that you can learn from?
Well, I think time is going to tell on that endpoint, which is I think if I remember correctly, sort of a combination of how long it takes to change treatment and how long it takes to fail the particular therapy, the embolotherapy that you're applying. And I think there's relevance to that. I think the idea that you can treat with a certain type of therapy and prolong that amount of time, I think certainly makes some sense. Is there a component of that is sort of morphed and modified to fit sort of the therapy? Probably, but that's no different than using, say, EMRISIS criteria for HCC or PERSIS criteria for PET scanning findings. So I think there's a combination here, and I think, again, time will tell. I think we need to get that data from Japan validated by another center. But the philosophy or the need to think about looking for novel endpoints, I think, is clearly there, because we've seen some failures of using TTP, and the initial enthusiasm about it translating to survival benefit hasn't really panned out. And, of course, local regional therapies and immunotherapies cause unique things like pseudo-progression, and the need to wait even though the lesions are getting larger, and changes in vascularity. So I think the spirit is there. I think there needs to be some more refining of that, but I think the spirit of trying to develop novel endpoints that are relevant for patients and move the field forward certainly are probably there.
I hear you. So let's go back to the current novel therapies that the whole presentation was about. And remember, we moved from sorafenib, as many of us already have reported or spoke about, and now we have regorafenib in second line, we have lenvatinib potentially in first line, we have cabazontrib potentially in second line, we have Rameshwaram potentially in second line with AFP more than 400, and we have, of course, already the conditional approval for nivolumab in second line. That's really an incredible change from one drug to 6 drugs literally in barely a year. And the question is that I have for Dr. Schwartz. So Myron, I could be wrong, but nonetheless, I'm trying to represent our colleagues as well here. The perception was that systemic therapy for HCC is kind of like the end of the road kind of message. Like, this is the best we can do, stability of disease is okay. But out of nothing, we hear, for example, a drug like lenvatinib with a 40.7% modified RECIST response rate. How do you read this? What does that mean to you?
Well, I think I can speak safely for the community of surgeons and people, local treaters, including interventional radiologists, and say that the whole view of this field is different. We now incorporate these drugs early into our treatment algorithms. We make every effort to get patients into trials because the lenvatinib may be 40. Lenvatinib plus immunotherapy, who knows, in renal it's 60. It's a tremendously exciting time that's led us to move away from the traditional pushing local regional treatments until the patient can no longer tolerate them, to getting patients onto systemic therapy early in cases outside of trials, not uncommonly in combination with local regional therapies, although that's an area that really needs to be studied carefully. But it's a whole new world. We couldn't be happier.
That's great to hear. And I go back to Dr. Salim. Riyad, teach us a little bit more. We'll make you now put your radiology hat of the many hats that you have, and tell us a little bit about modified RECIST versus RECIST 1.1. Tell us a little bit more.
Yeah, so we know that when it comes to local regional therapies, there has been traditionally several challenges, or there have been several challenges in assessing response and the importance of response because of the often inability of lesions to actually shrink in size, which is the premise of the original WHO and the RECIST and the RECIST 1.1. And so the modified RECIST were developed to incorporate the concept of vascularity or avascularity following treatment. And so what we wanted to capture is to make sure that just because a lesion did not decrease in size doesn't mean you haven't killed it and haven't caused necrosis. And so measuring vascularity has become very important. We eliminate and kill the vascularity when we ablate lesions. We obstruct the vascularity when we embolize lesions. And of course, with some of the systemic therapies, they can alter the vascularity as well, and we've seen that with some of the data from France and from the UK as well. And so the principle here is to capture the response, again, tailoring it to the mechanism of action. And so it's a little bit like I was saying about untreatable progression when it came to the tactics clinical trial. This is a way to try to improve and better capture the reality as opposed to waiting for lesion shrinkage. Now, there still is some decrease in size that happens with RECIST. Local regional therapies still cause 30-40% reduction in size, but when it comes to modified RECIST, it's about 50, 60, 70%, depending on the studies that you're looking at. So again, it's just a way to try to tailor and to make sure that you're capturing the true effect rather than be hampered by a tool that may have certain limitations, particularly size.
Great, that's extremely helpful. Yeah, go ahead.
Yeah, I've always found modified RECIST to be very useful in embolization, ablation, where it's literally black and white, whereas the changes that occur with the systemic therapies often can result in a spectrum of shades of gray. And I don't know, Riyad, do you think that it's as useful in systemic therapies as it is in local regional therapies?
You mean modified RECIST?
Yeah.
Well, it's certainly used, and it's certainly used to report sort of augmented rates of response. My only concern with systemic therapies, and I've observed this here, is that it can often be artifactual, and the vascularity can return quickly after the agent is discontinued. I'm sure Ghassan and Lewis have seen that. And so if something is avascular on an agent and then 4 weeks later all the vascularity returns because you discontinue an agent, then you can't really call it necrosis because it really wasn't necrotic, it was just flow artifact. But I agree with you. I hear sort of a little bit of the skepticism. It's being studied, but I think it's something that we have to watch out for.
I hear you both loud and clear in that regard, even though interestingly, for example, in the Lymphotinib data, it's not like the RECIST 1.1 was any worse. It was like close to about 25%. But with this said, I go back to Dr. Roberts. So, Lewis, one of the probably most commonly asked question at the moment, and already we were asked that, and I'm sure we're all approached with the same question, is how to pick and choose between the different TKIs. And let's start at least from one perspective, and we might tackle others based on what questions we get. But let's start from the perspective, hepatitis B versus hepatitis C. What does that mean? Are they really just a different flavor of the same disease? Are they different disease to begin with? And what does really the outcome will depend on for those two based on a specific TKI?
Yes, that's an excellent question. I think the data is still in flux or in development. But for example, some of the early data that we had with sorafenib, we had a fairly strong suggestion that individuals who had hepatitis C appear to be more likely to have responses than individuals who had hepatitis B, even though if we look at the trials that were done that had the worldwide trial versus the Asia trial, the Asia trial had a preponderance of patients with hepatitis B-induced cancer and still showed a significant benefit. So clearly, all patients show a benefit, but it seemed as though those with hepatitis C in some ways had got a preferential benefit. Why is that? Well, there's data that suggests, and this is where the region where the cancer is occurring also seems to be important. We know that, for example, that individuals in Asia are more likely to be exposed to aflatoxin, more likely to have p53 mutations, and so that there are likely to be differences in the profile of mutations that their tumors have and other aberrations compared to individuals in other countries. And maybe that's part of the underlying difference in pathogenesis that's been reflected by differences in response.
I hear you. And along that same line, while we're on the same subject, I'll ask Dr. Schwartz. So, Myron, tell us from your perspective, what does an AFP mean to you? Is it a diagnostic, prognostic, or nothing marker? Your thoughts?
The main value of alpha-fetoprotein at this point, I think, is being increasingly recognized as a prognostic marker as opposed to diagnostic, although I think now that hepatitis C is being cured and we have such a reduction in the number of patients with falsely elevated AFPs due to active hepatitis C, it's more useful in the screening and surveillance role as well. Maybe Lewis can comment on that. It's his expertise. But in the transplant world, for example, the criteria for eligibility have been altered this year to incorporate alpha-fetoprotein. Patients with alpha-fetoprotein levels over 1,000 are not eligible for priority on the transplantation waiting list, even if they have tumors within the size and number criteria that would enable them to have priority. If the tumor is treated, the AFP has to be brought below 500, and if it is, then the patient can get priority. But it's always, in every study of resection, it always comes out as an independent predictor, size for size, number for number of tumors. If the AFP is high, it's a predictor of recurrence and mortality.
Thank you so much, Myron. And go back to Lewis on the same question. So I think, understandably, the question was brought up in view of the advent of the Rameshwaram data that was reported at ASCO, and of course with the indication that the AFP might be representing a prognostic component here. Tell us a little bit, how do you read that data?
Yeah, so I think, what the data suggests is that individuals, and I think sort of thinking back to the biology question that we were discussing, I think what we're seeing is that AFP is a marker for a certain subset or subgroup of HCCs that seem to be more likely to respond to a particular subset of agents, in this case ramucirumab. And interestingly, even though overall these tumors have a worse prognosis of the range of HCCs, they're most likely to respond to this particular drug. So in a sense, it's leading us closer to the idea of being able to personalize therapy for patients, where ideally we get to the point where we understand well enough the different subclasses of HCC that we can select the ideal therapy for individual patients.
I hear you, but don't teach me this. Don't we, for example, understand and expect that a patient with even local disease with the AFP in the millions with hepatitis B is a relatively have been seen, while a patient with metastatic disease with hepatitis C might have even AFP, which is like only 40. Where does the risk factor play a role in regard to the AFP?
Yeah, so I think it's in a sense a function of two different things. So within each group of HCCs, or within a group of HCCs, the likelihood of having a high AFP increases with the size of the lesion. So as tumors increase in size, they become more and more likely that there's a subclone in the tumor that makes AFP. On the other hand, we know that if you have tumors that are small, only a smaller fraction of them, maybe perhaps 20% of early-stage HCCs will have high AFP. And within the group of small or earlier-stage tumors, the ones that have high AFP appear to have a different type of biology. And so, for example, if you have hepatitis B-induced cancers, you will have within the group that have high AFP a different kind of biology from the ones that don't, and similarly for hepatitis C-induced cancers. The thing that becomes an additional consideration in the case of hepatitis C is the fact that when you have these cycles of significant injury and regeneration and repair that occur in the context of hepatitis C, the regeneration is often associated with release and production of alpha-fetoprotein. But that's not necessarily so much from the tumor as it's from the regenerative capacity that's occurring in the liver. But that can be confusing because you may then have patients who have HCC that necessarily the HCC itself may not necessarily be producing the AFP, but in the context of a regeneration, they may have elevated AFPs.
Great, thank you so much. And one question we just got. So, Dr. Salim, Riyad, tell us a little bit about what's the ceramic study?
The ceramic study. Oh, yes. Okay, yes. So the ceramic study, as I understand it, is a European-based study that was looking at HCC and imaging and stratifying patients into curative and palliative arms, and the addition of sorafenib in I think one of those arms, maybe even the second one, but in one of those arms. I know that the data has not been published, but it was just recently reported, I believe, at EASL by Dr. Ricke, who I think is the PI. And I believe, and hopefully I'm not incorrect here, that the data was not positive in the sense of inability to demonstrate the benefit of sorafenib in the local regional therapy arm. but I believe that was the spirit of the study, and we're obviously waiting for the publication. But I think there was both a curative and a palliative component with imaging and the addition of a TKI.
You're absolutely right. I definitely I read it as negative as well, but definitely it was a genuine effort as well. But with this, I would like to thank you, especially thank you all our listeners and colleagues for attending today's webinar. And of course, I would like to thank all three faculty members who joined me today, Dr. Roberts, Dr. Salim, and Dr. Schwartz. This was an incredible and amazing discussion. And please remember, to be eligible for continuing medical education credit for today's activity, log on to www.naccme.com, and you have to successfully complete 10 questions that are post-test and evaluation form, and you can immediately print your document of credit. If anything, it's really remain a great honor to continue to work with the North American Center for Continuing Medical Education, who really did an incredible job, and would like to thank them and congratulate them on this effort. And with this, this concludes today's session. Thank you again for joining us.
Thank you.
Thank you. It's been a pleasure.
Thank you.